When we think about influenza complications, we typically think of pneumonia, particularly in the elderly or those with chronic lung disease. But one of the most significant and underappreciated complications of flu is cardiovascular. Research consistently shows that the risk of heart attack or stroke increases 3 to 5-fold in the first 7 days after influenza infection. This association is so strong that flu vaccination, simply preventing the infection, reduces cardiovascular events by 15 to 45% in at-risk populations. Yet flu vaccination rates remain suboptimal, and the connection between respiratory infection and cardiovascular catastrophe remains poorly understood by the general public. The mechanisms linking influenza to cardiovascular events are multiple and synergistic. First, systemic inflammation. Influenza triggers a massive inflammatory response with release of cytokines, inflammatory signaling molecules that circulate throughout the body. These cytokines don't just fight the virus, they also destabilize atherosclerotic plaques. Remember that plaques in arteries have a fibrous cap covering a lipid-rich core. Inflammatory cells digest this cap, making it thin and prone to rupture. When the cap ruptures, the core contacts blood, triggering clot formation and acute vessel blockage. Second, blood coagulation changes. Infection activates the clotting cascade and makes platelets stickier. This prothrombotic state makes sense evolutionarily, preparing the body to stop bleeding from potential wounds, but in modern humans with atherosclerosis, it increases risk of unwanted clots in coronary and cerebral arteries. Third, influenza causes dehydration through fever, sweating, and reduced fluid intake when you're feeling terrible. We've already discussed how dehydration increases blood viscosity and clotting risk. The metabolic demands of fighting infection stress an already compromised cardiovascular system. Fever increases heart rate, often substantially. A 100-degree fever might elevate heart rate by 20 to 30 beats per minute. This increased cardiac workload requires increased oxygen delivery to heart muscle, but coronary arteries may not be able to provide it. The combination of increased demand and fixed supply creates the substrate for myocardial infarction. Direct viral effects on the cardiovascular system also occur. Influenza virus can infect endothelial cells lining blood vessels and cardiac muscle cells, causing myocarditis and pericarditis. While these direct infections are relatively uncommon, they represent severe complications when they occur. More commonly, the viral infection triggers autonomic nervous system dysfunction, creating abnormal heart rate and blood pressure regulation. The timing of peak cardiovascular risk after infection onset has important implications. The highest risk occurs in the first 7 days, particularly days 2 through 5. This means that when someone has flu symptoms, they should be hypervigilant for cardiovascular symptoms during that week. Chest discomfort, unusual shortness of breath, severe fatigue beyond what the flu itself would cause. These warrant urgent medical evaluation, not just waiting to see if the flu resolves. Prevention through vaccination becomes not just about avoiding flu symptoms, but about cardiovascular protection. The flu vaccine is imperfect, typically 50 to 60% effective in preventing infection, but even when it doesn't prevent infection entirely, it often reduces severity. This matters because severe influenza creates more inflammation and more cardiovascular stress than mild influenza. So vaccination provides cardiovascular benefit even when breakthrough infections occur. The timing of vaccination matters. Immunity takes about 2 weeks to develop after vaccination, and protection wanes over several months. Getting vaccinated too early in fall means potentially waning immunity by peak flu season in January and February. Getting vaccinated too late means being unprotected during early flu season. Most experts recommend vaccination in October for optimal timing, though any vaccination is better than none. For people who do develop influenza, Early antiviral treatment with medications like oseltamivir reduces both symptom duration and complication risk when started within the first 48 hours. For those with cardiovascular disease, the threshold for starting antivirals should be low. Aggressive hydration, rest, and monitoring for warning signs of cardiovascular complications should be standard practice. Some cardiologists recommend temporarily increasing aspirin doses or adjusting other cardiac medications during acute illness, though this should be individualized under medical supervision. The intersection of infectious disease and cardiology reminds us that the body is an integrated system. A respiratory virus doesn't stay confined to the lungs. It triggers systemic responses that can kill through cardiac rather than pulmonary mechanisms. This understanding should motivate both prevention through vaccination and heightened awareness during illness.